We'll be breaking down all major concepts covered on the exam. So imagine a 25-year-old patient walking right into your clinic. On the outside, I mean, she looks perfectly healthy,
Right.
but then the blood pressure cuff is reading this terrifying, like 210 over 120. It looks like a typo, but it really isn't. Welcome in, everyone. As your MCCQE reviewers, our entire mission is to help you, the Canadian medical student, feel, more comfortable, more confident, and frankly, just a lot less overwhelmed with this whole exam review process.
Yeah, so grab your notes, because today we are taking a deep dive into Section SO5, Renal Medicine. Specifically, we're dissecting renal artery stenosis.
Yeah.
But before we get into the heavy physiology, just a quick disclaimer. Today's dive is sourced from reliable, peer-reviewed StatPearls articles.
Always important to mention.
Exactly. And this discussion is strictly for medical education only, not medical advice. Any actual clinical decisions always need to involve a qualified healthcare provider.
Absolutely. So let's jump right back into that 25-year-old patient scenario. By definition, renal artery stenosis, or RAS, is, well, it's pretty straightforward. It's just the narrowing of one or both of the renal arteries.
Right, the plumbing is backed up.
Yeah, but in the grand scheme of hypertension, this specific condition is a massive outlier that the MCCQE just loves to test.
Oh, it really is. I mean, it is the ultimate wolf in sheep's clothing for secondary hypertension. Because in the general adult population, primary or essential hypertension is just everywhere, right?
Right, it's super common.
But RAS, it might only be responsible for like 1 to 10% of all those cases overall. The real exam relevance kicks in when you look at patients with acute, severe, or refractory hypertension. In those specific populations, the prevalence of RAS shoots up dramatically. It lands somewhere between, well, 10 and 40%.
Wow, 10 to 40%. That means to spot this on the exam, you can't just look at the blood pressure reading. You really have to look at the demographic profile of the person sitting on the exam table in the vignette.
Exactly. You have to look at the who, because there are two completely distinct patient profiles showing up in these questions. Unilateral renal artery stenosis is primarily driven by two very different etiologies.
Okay, let's break those down.
So the first one, and by far the most common, is atherosclerosis. Here, you're looking at patients usually over the age of 50. This pathology is a massive player in older demographics, causing anywhere from like 5 to 22% of advanced renal disease.
And since it's atherosclerosis, I mean, we are looking at a very long chronic timeline of damage, right?
Yeah, exactly. The initiators of that endothelial injury are all the classic cardiovascular risk factors you already know from cardiology.
So long-term dyslipidemia, heavy cigarette smoking.
Yep, increased homocysteine levels, or even chronic viral and immune injuries. Over decades, these factors increase endothelial permeability. Macrophages migrate into the vessel wall, smooth muscle cells proliferate, and you get this slow, progressive buildup of an atherosclerotic plaque.
And that plaque just physically chokes off the renal artery over time.
Exactly. It's a slow burn.
Okay, so that covers the older demographic. But, that doesn't explain the 25-year-old from our opening scenario. She hasn't been smoking for 40 years.
Right. And that brings us to the second etiology, fibromuscular dysplasia, or FMD. This one presents a striking contrast. It's significantly more common in females than in males, and it usually presents in younger adults.
So, classic young female patient with sudden high blood pressure.
Bingo. When FMD strikes, it involves the renal arteries in about 75 to 80% of cases. And even more critically, for your vignette recognition, roughly 2/3 of those FMD patients will have multiple renal arteries involved simultaneously.
Oh, wow. 2/3. So think of atherosclerosis and FMD as two completely different suspects committing the exact same crime.
I like that.
Yeah, it's like atherosclerosis is the older chronic offender with a long rap sheet of smoking and high cholesterol, slowly casing the joint over decades. But then FMD is the unexpected younger suspect, often a young female, striking abruptly and hitting multiple locations at once.
That is a perfect way to remember it. Keeping those two profiles separate in your mind will absolutely save you points on the exam. A 65-year-old male smoker with high cholesterol and a sudden spike in blood pressure, that points straight to atherosclerosis.
Right.
But a young female with sudden severe hypertension, your brain should immediately jump to FMD.
So if the end result of both these diseases is simply a narrowed pipe, the real question is, how does a local plumbing issue in the kidney translate into a massive systemic blood pressure crisis for the entire body?
It essentially comes down to a desperate survival mechanism. The kidney naturally receives a massive portion of the body's total cardiac output. It relies on that constant perfusion, which drives glomerular capillary hydrostatic pressure, just to maintain its GFR.
So it needs that high pressure to filter properly.
Yeah, exactly. When a stenosis chokes off that flow, it creates chronic ischemia. The kidney is essentially suffocating. So the juxtaglomerular apparatus, the JGA, senses this drop in perfusion pressure and basically panics.
And it responds by dumping the enzyme renin directly into the bloodstream.
Yes, which kicks off the whole RAAS cascade.
Right, so renin converts circulating angiotensinogen into angiotensin I. Then, as that blood passes through the lungs, ACE converts it into angiotensin II.
And we know angiotensin II is one of the most potent molecules in the human body.
It really is.
It forces massive systemic vasoconstriction, clamping down on blood vessels literally everywhere. Simultaneously, it triggers the release of aldosterone, which forces the kidneys to retain sodium and water.
So the physics here are just brutal. You are drastically shrinking the volume of the vascular container with the vasoconstriction while simultaneously stuffing more fluid inside it with the sodium retention.
Exactly. The result is severe secondary hypertension.
The kidney is basically sacrificing the entire cardiovascular system, driving systemic blood pressure to dangerous heights, just to force a little more blood past that stenotic blockage to increase its own local perfusion pressure.
It is a ruthless local autoregulation. And, the kidney uses that same angiotensin II to modulate its own afferent and efferent arterioles, keeping its local filtration steady despite the blockage.
It's incredibly selfish, but it works.
It works beautifully to protect the kidney, yet right up until the renal perfusion pressure drops below a critical threshold, which is typically around 70 to 85 millimeters of mercury.
Wait, let me push back on that for a second.
Yeah.
So if a patient has a moderate blockage, say like a 40% narrowing, they aren't actually experiencing severe tissue hypoxia yet. They can just stay in that compensated state for years without irreversible fibrosis.
They absolutely can, and that is a major physiological concept for the exam. With a moderate reduction in perfusion, tissue oxygenation within the kidney cortex and medulla actually adapts.
Really, it just adapts.
Yeah, the tissue doesn't instantly die just because flow is reduced by 30 or 40%. This adaptation is exactly why early-stage patients can be managed purely with medical therapy for long periods without suffering progressive loss of renal function.
Okay, so the million-dollar question for the physician then is knowing exactly when that adaptation fails. At what percentage of narrowing does the kidney actually start dying?
The real danger zone hits at 70 to 80% vascular occlusion. At that extreme, autoregulation collapses entirely. Demonstrable cortical hypoxia sets in.
And that's when the tissue damage starts.
Right. The lack of oxygen causes microvessel rarefaction.
Meaning the tiny capillary beds within the kidney literally begin to disappear.
Exactly. They just vanish. And without those capillaries, inflammatory and oxidative pathways activate, replacing healthy functioning tissue with dense interstitial fibrosis.
Oh man, so it scars over.
Yes. And once that parenchymal scarring sets in, the damage is permanent. Restoring blood flow at that late stage provides absolutely no recovery of function.
Wow, so we really have to catch this condition before that irreversible fibrosis takes over. But since we obviously can't see the microvessels dying inside the patient, we have to rely on the physical trail of destruction that this massive systemic pressure leaves behind.
Right, the clinical clues.
Exactly. So what clinical clues are the MCCQE examiners going to hide in the vignette?
Well, age of onset is your first major clue, like we said. Hypertension before age 30 screams FMD. Severe hypertension abruptly starting after age 55 points to atherosclerosis.
Okay. Age is step one. What else?
Beyond age, look at the nature of the blood pressure itself. Vignettes will describe accelerated, resistant, or malignant hypertension. If you read about a patient who is on 3 different classes of antihypertensives at maximum doses, including a diuretic, and their blood pressure is still just through the roof, that is the classic hallmark of secondary renovascular hypertension.
Got it. What about physical exam findings? I mean, if the blood is being forced through a severely narrowed renal artery at such high pressure, we should be able to hear the turbulence, right?
Yes, you often hear it as an abdominal or flank route. The sheer force of that turbulent flow creates an audible whoosh on auscultation.
Makes sense.
You should also look at the eyes. Severe retinopathy on a fundoscopic exam is really common because the delicate capillaries in the retina are simply blowing out from the massive systemic hydrostatic pressure.
That's terrifying. And I imagine imaging would show a noticeable difference between the two kidneys in unilateral cases, right? One kidney is starving and suffocating while the other is getting absolutely battered by high systemic pressure.
Exactly. That leads to the classic finding of unexplained asymmetric kidneys, which is defined as a size difference of more than 1.5 centimeters between the left and right side.
So the ischemic kidney basically becomes unilaterally atrophic.
It shrinks, yeah. And here is another absolute highest yield presentation you will see on the exam. It involves the lungs.
Okay, the lungs, let's hear it.
If a vignette describes a 60-year-old smoker presenting with uncontrolled hypertension who suddenly develops unexplained flash pulmonary edema, RAS should be at the very top of your differential.
Ah, flash pulmonary edema. That actually makes perfect physiological sense here. The left ventricle is suddenly facing a literal brick wall of clamped down arterioles from all that angiotensin II.
Yep.
It can't pump against that massive afterload, so the fluid just rapidly backs up straight into the pulmonary circuit.
That is exactly the mechanism. That combination of flash pulmonary edema and resistant hypertension is a massive red flag.
Definitely.
But there is one more classic exam trap that students fall for regarding the clinical presentation, and it actually involves a routine medication reaction.
Oh, I think I know where this is going.
Probably. So a patient comes into the clinic with high blood pressure. You start them on an ACE inhibitor or an ARB, which, is standard of care for primary hypertension.
Yeah.
But a few days later, they return with unexplained acute renal dysfunction. Their serum creatinine has suddenly spiked out of nowhere.
Because you just knocked out the chemical crutch the stenotic kidney was using to survive.
Exactly.
Yeah.
We established earlier that the ischemic kidney is desperately relying on angiotensin II to squeeze the efferent arteriole and maintain its GFR.
Right, that local autoregulation.
So if you prescribe an ACE inhibitor, you block the production of angiotensin II, the efferent arteriole relaxes, and the filtration rate in that specific kidney plummets to basically zero.
And if the patient happens to have bilateral stenosis, or if they only have one functioning kidney to begin with, knocking out that autoregulation will just crash their entire global renal function.
Which is exactly why you see that massive creatinine spike.
Okay, so if a patient presents with these clues, the brutes, the asymmetric kidneys, the flash pulmonary edema, or that terrifying creatinine spike after starting an ACE inhibitor, we need to prove it's RAS. But we obviously want to avoid jumping straight to invasive, dangerous procedures just to take a look.
Right. So the workup always starts with basic initial labs. BUN, creatinine, a 24-hour urine for protein, and serology for markers like SLE or vasculitis.
Just to rule out other inflammatory causes of secondary hypertension, right?
Exactly. Once those basics confirm your clinical suspicion of a renovascular issue, then you have to actually visualize the arteries.
No, conventional renal arteriography is the gold standard for visualizing those vessels, but, poking holes in arteries isn't something we do lightly.
No, it's not. Arteriography carries significant risks. You have to puncture an artery, which risks atheroembolism, and it requires a moderate amount of iodinated contrast, carrying the risk of contrast-induced acute tubular necrosis.
So we avoid the gold standard until we absolutely need it.
Correct. We rely on non-invasive tests first. Duplex Doppler ultrasound is a great starting point because it's inexpensive, non-invasive, and uses absolutely no contrast.
But there's a catch.
There's always a catch. The major drawback is that it is highly operator-dependent. If the ultrasound tech isn't highly experienced with renal vasculature, the stenosis is very, very easy to miss.
So if ultrasound is too operator-dependent, the next logical step would be cross-sectional imaging, like a CT or MRI, to get a really clear 3D picture. But wait, doesn't CT contrast carry its own heavy risks for a patient whose kidney function might already be, teetering on the edge?
It does. CT angiography provides a beautiful 3D reconstruction of the entire renal vascular tree and easily spots accessory arteries, but you run the very real risk of contrast-associated nephropathy. MR angiography is an alternative that avoids nephrotoxic iodinated contrast entirely, and it's excellent for spotting narrowing in the proximal 3 to 3.5 centimeters of the renal artery.
Okay, what are the blind spots for MRA then?
It is poor at visualizing distal or segmental stenosis, and it is strictly contraindicated if the patient has metallic stents.
That makes sense. Now, there is one diagnostic test mentioned in the sources that feels less like imaging and more like, an elegant physiological trap set by the physician. I'm talking about ACE inhibitor scintigraphy.
Oh, it is a brilliant diagnostic tool because it uses the exact pathophysiology of the disease to prove its existence. The patient is given an oral dose of captopril 1 hour prior to the test, or an IV dose of enalactor 15 minutes prior.
So we're giving them an ACE inhibitor on purpose.
Yes. By administering this ACE inhibitor, you intentionally cause the GFR in the affected kidney to plummet, stripping away its ability to produce angiotensin II. The healthy contralateral kidney, assuming it isn't stenotic, preserves its overall function just fine.
So we chemically paralyze the affected kidney. But how do we translate that temporary paralysis into something we can actually see on a scan?
We inject a radiotracer, typically technetium-99 mag or iodine-131 OIH. These specific tracers undergo tubular secretion.
Okay.
In a normal, healthy kidney, the tracer is secreted into the tubules and passes right through the plumbing into the bladder. But in a kidney affected by RAS that has just been functionally paralyzed by the ACE inhibitor, the decreased urinary output and crashed GFR mean the tracer cannot be flushed out. It just gets stuck in the renal parenchyma.
It's essentially a stress test for the kidney's autoregulation. You're intentionally kicking away the kidney's chemical crutch just to watch it stumble and drop the tracer on the imaging screen.
That's exactly what you're doing. You are inducing a temporary functional failure to prove the kidney's absolute dependence on the RAAS pathway.
And then you just image it.
Yeah, you take sequential images for 30 minutes. If you see unilateral parenchymal retention, which is measured as a change in the 20-minute peak uptake ratio of 0.15 or greater, or a significant delay in excretion into the renal pelvis, that represents a greater than 90% probability of renovascular hypertension.
That's incredibly specific.
It is. But there is one critical logistical detail for the exam. You must have the patient cease any pre-existing ACE inhibitor therapy 2 to 5 days before this study. If they're already taking the drug, the test baseline will be completely skewed.
Naturally. Okay, so now we have the patient profile, the pathophysiology, the clinical clues, and the definitive diagnosis. The final hurdle for the exam is management. When do we just watch and medicate, and when do we actually send the patient to surgery to open the artery back up?
Well, the initial treatment for RAS might surprise some students. It is often medical management and observation, not immediate surgical revascularization.
Really? Just observation?
Yeah. Conservative management is indicated if the stenosis is less than 50% or if it's between 50 and 80%. But the scintigraphy findings are negative, meaning the flow is reduced, but there is no functional impairment of the GFR yet.
Okay, but observation still requires aggressive medical intervention to stop the progression, right? You don't just send them home with a pat on the back.
Oh, absolutely not. Patients require serial duplex scanning every 6 months to monitor the degree of narrowing. Medically, you are managing the underlying atherosclerosis with strict cholesterol control using statins and antiplatelet drugs to block further aggregation at the plaque site.
And obviously, blood pressure control.
Most importantly, yes, aggressive blood pressure control. These patients might require 3 or more different antihypertensive drugs just to get their numbers into a safe range.
Okay, wait. The choice of those blood pressure medications introduces one of the most diabolical paradoxes in renal medicine.
The ACE inhibitor paradigm.
Yes, because the preferred drugs are ACE inhibitors or angiotensin receptor blockers. But we literally just spent the last 10 minutes establishing that giving an ACE inhibitor to a patient with bilateral RAS is a massive exam trap that can trigger acute renal failure. So how can it be the preferred drug?
It's tested constantly because it requires you to understand the difference between unilateral and bilateral disease. ACE inhibitors are the absolute best drugs to control renovascular hypertension in unilateral cases because they directly counteract the RAAS overactivation that is causing the systemic high blood pressure. They treat the actual root cause.
Okay, but if they have bilateral stenosis or a solitary kidney, you are knocking out the autoregulation for their entire remaining renal mass.
Exactly, which is why you must monitor their serum creatinine and potassium levels like a hawk when initiating this therapy.
Oh.
Even in unilateral cases, ACE inhibitors can lead to increased serum creatinine levels and hyperkalemia.
So what happens if the labs come back bad?
If the creatinine spikes unacceptably or potassium gets dangerously high, you must pivot immediately. Calcium channel blockers serve as the reliable, safe backup replacement if ACE inhibitors are no longer tolerated.
All right, so medical management holds the line for a while. What are the specific criteria that tell us, medications are no longer enough and we need to physically revascularize the artery?
The degree of stenosis that justifies an intervention attempt is generally greater than 80%, particularly in patients with bilateral stenosis or stenosis in a solitary functioning kidney.
Makes sense.
The guidelines dictate action based on the patient's current renal function. If renal function is currently normal or nearly normal, you recommend revascularization to prevent future insufficiency under specific conditions.
HR.
If the hypertension becomes completely refractory to maximal medical therapy, if the patient is severely non-compliant with their medications, or if they experience that classic presentation of recurrent flash pulmonary edema.
Okay, but what if the renal function is already showing signs of failure?
When renal function abnormality is already present, the urgency definitely increases. You intervene if there is progressive documented worsening of their renal function, or if they have a worsening clinical condition, specifically in the setting of bilateral lesions or a solitary kidney.
Because you're running out of time.
Exactly. The surgical goal here is to restore flow to salvage whatever functioning microvessels are left before that irreversible interstitial fibrosis completely consumes the organ.
Man, that is a staggering amount of high-yield physiology and clinical reasoning packed into a single condition. Let's distill the absolute must-knows for the MCCQE. First, anchor your clinical vignettes to the demographics. Atherosclerosis is your older patient with chronic cardiovascular risk factors, while FMD is your younger female patient with sudden, severe multivessel hypertension.
Spot on. Second, visualize the trail of damage left by the RAS cascade. Look for unexplained asymmetric kidneys on imaging, listen for abdominal brutes, and immediately suspect RAS if you see flash pulmonary edema paired with resistant hypertension.
Third, respect the ACE inhibitor paradox. It is the mechanism that makes the scintigraphy stress test work. It is a dangerous trap for inducing into renal failure in bilateral disease, and yet it remains the preferred medical therapy for unilateral cases.
Right.
Finally, remember that revascularization is reserved for severe cases, usually greater than 80% stenosis, bilateral disease, or when medical management is outright failing.
For those of you studying, try to review these algorithms not just as memorized lists, but as a continuous physiological story. Notice how intimately intertwined the diagnostic workup and the management guidelines are with the underlying RAAS cascade. If you truly understand how the ischemic kidney autoregulates, the rest of the clinical picture just falls perfectly into place.
The pathophysiology literally writes the rules for everything else.
It really does. And as you head back to your notes, I want to leave you with a broader concept to ponder. We spent a lot of time today discussing microvessel rarefaction, the literal disappearance of capillary beds and the resulting interstitial fibrosis happening inside an ischemic kidney.
Yeah, the irreversible scarring.
Right. Well, it makes you wonder how much of general age-related systemic decline is actually just unrecognized. Microscopic stenosis happening in capillary beds across our entire body. What if aging itself is, in part, just a silent global version of ischemic nephropathy?
Oh, wow. That is a wildly profound way to look at human aging, and definitely something to think about during your next study block. That brings us to the end of today's deep dive. Keep crushing those practice questions, trust your clinical reasoning, and good luck with your exam prep.